Thank you very much. Thank you very much for the introduction, Tiago. Thank you to all of you, our speakers and the participants. And I just give you a very, very brief idea on how and why we are doing this. So the aim with these webinar series is that we move from crisis to the capacities, and the webinar series is very closely connected to a special issue that we have done with a group of editors for health policy recently. So for this webinar, we have selected the topic retention, and we have 4 speakers. But I want to highlight that we have 4 speakers who will present their research, and then we have 3 commentators. So that means we have a very, very big agenda. We will be very brief, but you have the 4 papers that will be presented, that you have them all available in our editorial in the special issue, and Tiago will also put the links in the chat. With the webinar, we believe we have really a great opportunity to connect evidence, research evidence on the one hand, and commands and policy from leading organizations in the field. And we also tried to make it more diverse. We began with a panel discussion with the 4 papers, to be very briefly, not the papers, just key issues to be introduced. And then we will move on with the commentators. And then we have a Q&A section moderated by Tiago. And last time we really managed that we have time for that. I'm pretty sure it will also work this time. So everybody is welcome to put your comments in the chat, please. So having said this, I'm very happy to introduce our 4 panelists at first, who present the research. That's Erika Richardson from the European Observatory on Health Systems and Policies in London, Alicia Domagala from the University of Krakow in Poland, Paul Künzle from Charité University in Berlin, and then Martin Fellner from Erasmus University Rotterdam in the Netherlands. We move on in this order, and the same question to all of you 3, based on your research. What evidence and novel approaches are available to build capacity for retention and for resilience of the health and care workforce? The floor is yours. We start with Erika. Thank you.
Thank you very much. It's a real pleasure to be here and have the opportunity to share some of the findings from our small paper in the special issue. Please do follow the link in the chat to check it out. It's also a real pleasure to see some of my co-authors in the audience who are able to give you more specialist, detailed information on Cyprus and things like this. So our paper drew on health systems reviews recently published by the European Observatory on Health Systems and Policies. These reviews were for Cyprus, Luxembourg, North Macedonia, and the Caribbean Netherlands. We published these reviews as a core part of our country monitoring work. And I will share a link to our HIP profile series, as it's known, in the chat in case you wanted to find out more detail about all of these individual countries. So our paper aimed to explore the specific challenges small countries face in the education and retention of health professionals, but also the policy responses that have lessons for all countries. Now, small countries have a population of fewer than about 2 million people, and the challenges they face are often linked to the capacity constraints that are inherent to their size. Now, while there are specific challenges in small countries, these exacerbate common challenges that affect all countries in the European region. So the solutions and responses from small countries still actually provide useful insights for larger countries looking to strengthen health workforce resilience. Now, while building selective in-country capacity to train health professionals has been a part of the solution, particularly in Cyprus and Luxembourg, one of the most notable aspects of building capacity in countries with smaller populations is that they do not try to do it all alone. They work closely with other, often larger, countries in Europe to facilitate both cross-border care where necessary, but also for the training of health professionals, particularly for specialist training. Now, for policymakers, this can seem risky. Training health workers in other countries could be seen as facilitating migration. But the experience of small countries show that it is possible to leverage structured mobility using rotations, twinning, and EU schemes such as Erasmus+, to import skills while keeping professionals connected to home systems. Small countries therefore show us that mobility does not have to be a bad thing for retention. What matters, of course, is designing career pathways beyond pay scales. Tackling push factors through clear advancement routes, continuing professional development, and protected time for training, especially for nurses and allied professions. It can be a good thing for your health professionals to gain experience in other countries, and it could be argued that such skill sharing across borders is good for everybody and has the potential to increase overall retention. And this is true for all countries, whatever their size. Thank you very much. Back to you, Ellen.
Ellen, you are muted.
Apologies. Alicia, please could you go on? We move on and on in the program. Sorry for that.
Yes, thank you. So based on our comparative research on policies targeting young doctors in Poland and the United Kingdom, there is clear evidence that recruitment and retention of health workers is a complex challenge that requires much more than only increasing salaries or expanding medical training, for example, by increasing medical students or medical graduates. The youngest generation of healthcare professionals differs significantly from older generations in many ways. As we know, the ability to maintain a healthy work-life balance is becoming one of the most important factors considered by young people in their professional lives. What does it mean? They are less willing to accept workload and current workplace cultures, and they place strong importance on supportive environments and flexibility. So consequently, improving retention and resilience depends on meaningful engagement with this generation, adapting system to their expectations, and co-creating policies with those who will ultimately build and sustain future healthcare system. Evidence consistently shows that everyday working conditions are the most powerful determinants of retention. Flexibility, supportive leadership, friendly working atmosphere, and support of mental health are strongly associated with intention to stay. At the same time, health systems need to invest in solutions that matter to this generation, including reducing administrative burden through implementation of digital tools, improving team-based care, and ensuring flexible and supportive work environments. This also requires predictable pay structure, adherence to safe working hours, and organizational culture that value autonomy and well-being. So furthermore, career development and mentoring play a critical role. Early career doctors who receive support, particularly mentoring and opportunities for professional development, are significantly more likely to remain in their profession. Embedding these elements, mentoring development as permanent, not optional, but permanent rules of workforce policy is essential for long-term resilience. In addition, place-based incentive packages are more effective than isolated financial bonuses. This combines salary adjustment with housing support, childcare support, or guaranteed supervision. This is particularly important in context of rural or underserved regions. And finally, curriculum reform. Medical education curriculum reform is an emerging priority. Aligning medical education with digital, data-driven, and team-based models of care better prepare future professionals for answer of health needs population and reduce gap between medical training and medical practices. So they are the key messages from our study, and I encourage you to explore the full text publication for more details. Thank you.
Thank you very much, Alicia. And we stay with the young generation and move on with Paul, please.
Thank you, Ellen, for the invitation, and thank you all for attending this webinar. Our research was created as part of the Global Health Workforce Network EUPHA, hosted by the Health Workforce Department at WHO. And our scoping review analyzed the financial challenges of students and early career professionals working in the healthcare sector. We structured our research in 3 different sections, including loans, debt, and its impact on career pathways, the role of early employment and salaries for career satisfaction, and the impacts on lifestyle and well-being. So I'll structure this talk right now in 3 sections. First, evidence, then evidence-based strategies, and then novel approaches. On our evidence, financial stress was found to be a primary driver. Attrition and low resilience are not random. They are structurally produced. High educational debt shapes career choices and pushes workers toward higher paying sectors rather than public or rural care. Low salaries and delayed financial stability reduce motivation and increase burnout and attrition. And limited access to scholarships, grants, and loan relief worsens inequities and workforce shortages. Work system pressures include poor working conditions, long hours, and lack of flexibility, driving dissatisfaction and exits, and migration is strongly linked to financial and career dissatisfaction. Lifestyle factors include burnout being exacerbated by financial strain and lack of work-life balance, and gender inequities and lack of family-friendly policies undermine retention. Now, number 2, evidence-based strategies to improve retention that could be derived from our research. Financial and economic interventions include reducing educational costs and debt. Tuition reduction, scholarships, and subsidized loans fall under this point. Increasing salaries and benefits, especially in public and rural sectors, and loan repayment and bonded schemes that could tie financial relief to service in underserved areas. Moreover, improving early career employment conditions, including access to stable contracts and career progression pathways, and better alignment between workload and compensation, and non-monetary initiatives, including housing, transport, childcare support, rural incentives and hardship allowances, and opportunities for dual practice and flexible contracts. Now, number 3, emerging approaches. Task shifting and team-based care, we've heard about it, but expanding roles of mid-level providers, including nursing and physician assistants, and redistributing workload across teams. AI-enabled and flexible education models, integration of AI-based learning tools in training, and providing on-demand modular continuing education. Including mentorship and peer support networks more strongly in healthcare, including structured mentoring systems and professional networks for emotional and career support. And lastly, data-driven workforce planning, so an expansion potentially of the national health workforce accounts and continuous monitoring of workforce trends. Lastly, in our review, we formulated the Youth Health Workforce Framework, so a novel systems approach proposed in the paper, diagnosing workforce challenges, number 1, then developing profession-specific solutions, number 2, implementing them through multi-stakeholder collaboration, number 3, and then lastly, building long-term data systems for monitoring. Thank you very much for your attention.
Thank you very much, Paul. And we move on with Martin, please.
Yes, thank you very much. Our paper is short titled Different Systems, Same Challenges, and it's a comparative study that starts from the premises that long-term care systems across OECD countries are under increasing pressure due to aging populations and persistent workforce shortages, and strengthening resilience has therefore become a shared policy and research priority. And we start from, we have an approach in which resilience is not an individual trait or a system level outcome, but rather something relational and emerging through the interaction between policy frameworks, organizational arrangements, and everyday care practices. And our aims with the papers were threefold: to compare long-term care systems across 7 countries, to identify shared workforce challenges, and analyze strategies used to strengthen resilience in these countries. And we included countries with very different system configurations, from tax-based models such as Norway and Spain to the insurance-based systems of the Netherlands. And they differ also in spending levels, reliance on informal care, and in workforce composition. For example, in the Netherlands and Australia, they rely much more on part-time employment, whereas the other countries relied much more on full-time employment. But despite these differences, all countries also face the similar workforce challenges, and demand for care is rising rapidly, while organizations struggle in particular with staff retention. And in addition, long-term care is characterized by relatively high sick leave rates. And these patterns are well known and already widely documented. But in response, we also found that countries are converging around 4 main strategies, which are aging in place policies, service integration, technological innovation, and workforce redesign through task shifting and upskilling. But while similar in direction, these strategies are implemented in very different systems. And we also observe variation in how task shifting is organized, particularly in the use of short-trained workers to support basic care processes and increase organizational flexibility. And these variations that we saw, they reflect the different ways in which countries, but also organizations within these countries, make trade-offs between accessibility, quality of care, and workforce sustainability at the front line. And based on these similarities and differences, we argue that resilience is not only about which resilience strategies are adopted, but also about how they are translated, weighted, and prioritized in practice. And this brings us to the main point in our paper, which is that a key but often overlooked actor in this process is the middle manager in healthcare organizations. And positioned between policy articulation and frontline care, middle managers translate strategies into practice, balance workforce pressures, and navigate competing demands. And it is at this level that crucial trade-offs are often negotiated. Yet we also found that relatively little attention is paid to how middle managers can best be supported in this role, both in policy and in academic debates on resilience. And we therefore argue that strengthening long-term care resilience requires a stronger focus on these middle managers, their role in translating strategies into practice, and how they can be supported in doing this effectively. Addressing this gap is a key contribution of an international and EU-funded research program titled Support for Resilience, which we also refer to in this paper, and which I recommend you to look up as well. Thanks.
Thank you very much to the 4 of you. And I think you gave us really a very, very broad picture from the younger to the older generation and the small countries and the comparison. And to make that even a little bit more complicated, I wanted just to briefly recall that we have some more papers, and we're not able, even more on retention, strongly focusing on retention. And I would like to mention at least 3. So there is one paper by Dutch on another review on long-term care. And we have also very interesting paper from Turkey on physicians during crises and how that impacts on retention in a long-term care perspective. And then we have a paper specifically focusing on the global local policy linkages using Romania as a case study. So please have a look in the special issue on the papers, but in the sake of time, we need to move on. And I'm looking very much forward now to our 3 commentators. And we have with us Monika Brinsack from the European Public Health Association, Dea Oman from the European Specialized Nurses Organization, ESNO, and Thomas Zapata from the WHO Regional Office for Europe. The similar or more or less same question to you is, based on your experience and policy approaches, how can we build capacities for retaining and for stronger resilient systems? Please, Monica, the floor is yours.
Thank you so much, Ellen. Congrats to all of the speakers. You have some great articles. And Ellen, what an easy question. I think that in 3-4 minutes, I will be able to provide a sufficient answer to fix all of our workforce issues. We at the European Public Association, European Public Health Association, we are doing many efforts to try and work on that. And as I'm also a teacher myself, and I'm teaching the next generation, and while also being a young person, I can say that this is a very difficult task because we see, as Alicia mentioned already, we need more investment, but investments are not, financial investments are not the fix-all solution. We need salaries, increases in salaries, but we see that the younger generation does not want only larger salaries, but also a better life-work balance, which for a doctor, for a nurse, for people working in the health system is quite complicated. Also, something that is quite difficult is the public health workforce. People working in public health are quite lonely. I've met so many people attending the European Public Health Conference, which this year will be in Bilbao, that said, they feel so good after the conference because they found a community. They found someone that they can talk with, resonate with. And this is also something that we need. We need a support group. We need people that we can collaborate with, complain to, and get hope from. And this is something that we're working on. EUPHA is currently working on the EUPHA Academy. We are working towards the professionalization of the public health workforce to have everything credited to create this community around the public health workforce. But also, we are looking at the retention of the people that are already in the system. So people that maybe are a bit older and that are tired of seeing that the system is not changing. How can we do that? Well, that is even a more complicated issue. And it's, I think, something that we have to accept, to be honest with people about. And we have to tell that change, real change, takes time. And we have to come together as one, which takes a lot of coordination, but this is something that we are here for. We want to be the place that people can come together, and maybe through having these lighthouses, beacons of hope, people will be willing to stay more in the system. So I think that what we can do is make sure that we offer people communities on top of investments in salaries, equipment, supplies, everything that needs, but also having policies that support the training of the people, making sure that we have the right skill set, making sure that we provide people with the community, the money, and the policies and the skills that they need to perform their job properly. I think if we have this mix, we might able to retain and attract more people to care for those that need it. Thank you.
Thank you very much. So we move on with Bea, and I must say I'm really glad that we have the nurses in, because we very often forget that the nurses are really, really the largest group. We are all important, but so the word is yours now.
Okay, thank you, Ellen. And it also was very great to have you two in our event half year ago in Brussels, when we also touched base on this crucial issue, and also was so very pleased that also Thomas was able just to be with us online, and it's also because the health workforce is not just a thing, what's an error or an issue in the system. It's very heartfelt for every nurse, and I think also Monica elaborated on this. It makes them feel very afraid. If I go to the station, am I alone there with 5 patients, or intensive care with 3? Or do I have to do another 4? And if I go home back again, how do I not feel guilty on the issues what I have not done. So if we look at health workforce shortage, we saw this coming from decades ago. And Thomas, he has all the data. He also is a very long standard history on this. So 20 years we saw this point coming. And 10 years we saw this coming, and 5 years ago we saw this coming, and then suddenly COVID drops in, and now we face at least a 10 to 20% drop of health professionals. And I do promote the advocate the world of the nurses, but we cannot do this alone because we are very much aligned with the pharmacists, with the general practitioners, with the medical specialists. So we are all on this. On this issue. But I also think sometimes we forget that nursing is more than skills education. Sometimes we think, well, often the nurses are, if well understood, the total manifestation of the health workforce. So if a patient comes into a hospital with a certain issue, or a certain crisis, then it's not about the care on the crisis, but the whole pathway. Then they have to go to the intensive care, to the recovery, to a new operation. We see, for example, for elderly patients, that at least 20% they have relapses, so they go back, and that's where the nurse is coming. And then we are very much dependent on the medical specialists to engage in this. And I also like what Monica also was stressed just a minute ago. If we're talking about the Gen Z, sometimes I also feel a bit like being a Gen Z guy. You see, we all evaluate. So I also recall that when I was at the end of my career, because I'm now retired, and I advocate the professions in the young generation, and we really need to keep them in the ward. But it's also well, at least 60% of the health workers are at the moment above 40s. So we have also to take care very much of the elderly domain, and those elderly domain, they are going to support the younger ones. How to keep them on board. And that's where you can say that the health system is really a home for the patients, but also a home for the health professionals. So this is a very more integrated aspect. So if we're talking about shortage, it's more than only the bits and the parts. I have a lot of comments here in my paper, but I put here one big word, and it's called mentorship. And I also heard that Paul Gonzalez also mentioned this. And mentorship will be very crucial in the upcoming years. If we discuss with nurses from the USA, they're very familiar that every nurse in their career, in their 4th or 5th year, that they're obliged to take at least 2 or 3 nurses in their mentorship. And in Europe, we are still a little bit afraid of that. Ooh, that's another talk, but it just gives pleasure. It gives joy. It gives a really great exchange. And I'm really pleased that the word mentorship is also appearing in the draft of the I&I report of the health workforces on the Sound Committee of the European Parliament. So I put in the chat just a last comment. There's a book created by the Z Encyclopedia. That's also very much where it's stated what we can do on retention. But it's also said, well, let's create a culture of a home where health is warm and not only ticking boxes. So let me close on here, and I'm very pleased to hand over to Thomas.
Thank you, Thomas. You're muted.
Thank you so much. Thank you, Helen, and thank you, Veerman. No, a real pleasure to be here and responding to your question, how we can improve retention of the health workforce and resilience of the health system. And one element that I would like to bring here is improving the mental health and well-being of the health workforce. I think is one of the critical factors. Last year, end of last year, we launched the largest ever survey conducted on mental health and well-being of health workers in the European region, more than 120,000 responses. And the results are really concerning. 1 in 3 nurses and doctors expressed symptoms compatible with depression in the previous year. 1 in 3. This is 5 times higher the prevalence in the overall population. When we look at anxiety, 1 in 4 had symptoms of anxiety. 10% reported suicidal ideation in the last year. So I think we really need to take this seriously. And as Bernd was mentioning before, I think after the COVID pandemic, there was a before and an after, and this is something we need to take seriously. But I think we need to go beyond just the picture of the situation. And also, since we were talking before about young professionals, what we see is that the mental health and well-being of the young professionals is worse than older doctors and nurses. So probably it's also because the poorer working conditions, but we need to look at that as well. And something important for us in the survey, in the report, was to look at what were the root causes, the risk factors contributing to this poor mental health. And for example, we found in terms of violence against health workers, 1 in 3 suffer or bullying or violent threats, and 10% physical violence. If we look at the working hours, 1 in 4 was working more than 50 hours per week, which is beyond the 48 hours directive of working hours of the European Union. So, and what is more important, what we were seeing is that there is a direct correlation between the working hours and anxiety and depression. The longer the working hours, the higher the anxiety and the higher the depression. We also look at the shift work, 34% of the nurses, 39% of the doctors doing 1 or more shift work per week. And this is also correlated to poor mental health. So temporary appointments, temporary contracts, uncertainty, another key element, another important risk factor. And then we also have some protective factors. It was also mentioned before, the importance of mid-level management and leadership, how that really makes a difference. In our survey, we really see that those health workers, doctors and nurses, that they feel supported, they have 2.5 lower chances of having anxiety and having depression. So that's as an important element. So in conclusion, I think it's really important that we work in improving these causes, these root causes and risk factors, which is basically improving the working conditions. And this has been mentioned by other speakers before: working hours, shift work, violence against health workers. We have the recommendations. I put the report online, but I think it's important that we put the focus in these structural factors and not just in the individual factors. The risk is in mental health that many times we put the focus of someone, a health worker, a nurse, a doctor, another health worker has depression, and then we put the psychologist, or we put the hotline, which is also important, but I think it's more important that we look at the structural working causes and improving the working conditions. Thank you.
Thank you so much to all of you. And I think you gave us very, very many important ideas, but there is this one issue that, Thomas, you just also said. It is a system issue. And that comes out of all your statements, looking at from very different professions and different age groups. It is a system issue. And that is the good news, I would say, because you can change systems. It's difficult to change people. We all know that, but you can change systems. That's not easy, but you can do. And your ideas gives us a lot of important guidance where we can start. So I just want to add one single point, which I think is a key issue and that we did not touch on. If we are talking about retention, if we are talking about the workforce, we are always talking, whether we mention it or not, we are always talking also about gender, because the health workforce is about three 75, 78%, wherever we look at, depending on the profession, it is women. And I think that is a key issue. And that applies to all issues, the working conditions, especially mental health, violence, and so on. But I'm very glad to hand over to Tiago because thanks to your time management, we have time for the chat. Tiago, please.
Thank you so much, Ellen. Thank you so much, everyone, for such insightful inputs and comments. As to the audience, you are not able to turn on your mic, but you are more than welcome to write your comments and your questions in the chat if you like. Just I was taking care of the chat. And first of all, you can see not only the links for the papers that were presented right now, but also more complementary reading, which I believe it's very helpful to frame the different points. And I would like to make Ellen's my own words. Sorry, I'm a bit sick today, so this grave voice. But the point, it's very important to address this issue as a systemic issue, and therefore it's manageable more than looking at the individual side. But one really important point is the importance. This was mentioned, and this comment is already in the chat. It's really important to change and to revise the training, initial training and lifelong training. We have here a clear example from the Ghent University, but I believe there are others. So one initial question or comment for our presenters and also commentators, if they want to elaborate more a bit on how the training, again, initial and lifelong training should evolve in order to embrace the different demands, challenges professionals, health and care workers face in their professional life. So any clear or very concrete examples on good practices, how the system is evolving in terms of the training. So I would like to hear more about this topic. Thank you. Very shortly, please, just to be sure that we are able to have several rounds. Anyone from the presenters, you are free to step in, or the commentators, so do not feel obliged for me to point you specifically. Yes, Bear. You are muted.
Oops. I think
Yes.
the system can be repaired, but it will go in parallel with the culture. Systems are often very budgetary minded, and the health system is very under high economical and budgetary pressure. It's everywhere. So we also see a shift from the public to the private, where also nurses go to the private because the conditions are easier, they have more handle, but that extracts nurses from the public domain. So we also need to have a very good look at the culture domain in the public sector. As I said, well, it really needs to be more a home. So, but I'd like to stress this as a kind of a balance. What Ellen says, well, systems can be prepared, but cultures also need to be changed.
Yeah, thank you so much. We have a hand raised by Jan. The floor is yours. I believe you are not able to turn on your mics. Eventually, you should write in the chat, okay?
Okay.
For technical.
Do you hear
oh,
me?
no, okay. So you can turn your mic on. So perfect.
Yes. Okay. Now, thanks for all this interesting contribution. And jumping into what the previous speaker said, I fully agree. It's not only an issue of a system; it's an issue of culture. And this culture, of course, is system defined. We have been shifting to a much more individualized, for private profit way of living. And that also you pay for in recruiting your healthcare workforce. Because in the society, taking care of each other is no more an essential part of our existence, unfortunately, because we will need it more than ever in the forthcoming decades. And that's a fundamental culture problem. So we undervalue care and we value those that are successful and make profit. So what I think is important in the different phases of the process, beginning with the training, we have to construct relationships between the people that are trained for healthcare professions and communities. And exposing people to communities, giving the positive experience that they can make a difference from the very early beginning of their training, I think is a very important and powerful way of motivating people. But it should be ongoing during the work period. And of course, there are things that you should not do. 3 shifts in a week, that's for no one okay. 2 shifts in a month is feasible. And that are essential things that are all over the place in the world the same. Apart from that, but I think it's the most important thing is that you can relate to the work you are doing and to the people you are working with. I speak of experience. 40 years I've been working in a multicultural community in Ghent. In the same community, I've seen this community evolving. I'm part of that community still nowadays, and that gives meaning to my function as family doctor. Because it gives the other dimension of becoming a reflective practitioner. That means you're not only there to react, you're there also to reflect and to contribute also to what I would call building of a caring society that takes into account everybody, also those that are most in need. And I think that these fundamental values, we will not solve the problem just by technical solutions. And I quoted a family doctor experiences with AI scribes. Well, he exactly explains what the problem is. We will not solve the problem by replacing doctors and nurses by AI. AI can be helpful to support them, but they've got the need to have the feeling that it is their own analysis, their own diagnosis, their own capacity that they can engage. And as a society, I think we should more negotiate a societal contract with the healthcare workforce. I think we do this with other groups, but we should also do that with the healthcare workforce to make clear that from our societal perspective, we want to invest. It is not a cost, it is an investment in quality, high quality healthcare providers, but we also expect them to give something back. And I think that that is also important. So doing work for less than half time, sorry, as a healthcare provider, that is very difficult. Not only for organizational reasons, for capacity reasons, but also for maintenance of your quality. If you are not exposed enough to problems, you will lose your expertise and you will lose your connection. And losing your connection is even worse than losing your expertise, I think, for healthcare providers. So that's my fundamental
sorry,
reflection.
can you just briefly end your comment, because
yes,
we would like,
I am there. I think that was the essence of what I was trying to say and to write. And we have to look also at this debate in a very open way.
Yeah, thank you so much. I think your insights are very clear, and thank you for those. Thomas, would you like to comment or to make an additional comment?
No, I think it's both. It's responding to your question and the good comment from Jan. Just very specific, I think, because you were asking now in the importance of how we train the health workers. And I think one key element for me is how we bring this human component and competency in the training of health workers. Now with AI fully developing, I think we really need to, our comparative advantage in a sense is that human component. I think we need to rethink how we select the medical students, the nursing students, so that is an important component of how we build those competencies during the training. I think it's something really important so that when they are out there providing health services, they can really complement bringing that human touch, that human component over. Thank you.
Absolutely, Thomas, and thank you so much for bringing or highlighting even more this point. Martin, would you like to bring something?
Yeah, thank you very much, and maybe not so much in relation to the paper that I introduced before, but more in relation to the discussion that we have now, and also in relation to the idea of training that you raised, Tiago. And I just wanted to point out as well, without becoming very cynical about this, but that if we look at long-term care, then we see also a new group of healthcare workers coming in with flexible contracts, low-paid work, and also limited protections from collective labor agreements, for instance, often also with a lot of intersectional challenges, single parenthood, migrational background, informal caregiving responsibilities. So it's layering. And then actually they are already in a very vulnerable position, and we ask them to be responsible for taking care of vulnerable people, while they are also struggling to make ends meet. And I think for me, or in the studies that we're doing now, and we're presenting this as well in the EUPHA Workforce Conference next week, to tease this out a little bit further. But for me, this is also an essential element in the high turnover, the problems around retention, but also the way in which we build this culture of care that others have been referring to as well, and maybe also how we think about this kind of societal contract that we have with this kind of nurse-aid professions within long-term care. So there are very interesting points here, but also this very vulnerable group that we ask to take care of vulnerable people, just to point that out. Yeah.
Yeah, thank you, Martin. Very clear as well. Thank you so much. Monica, would you like to add something?
Yes, so what I wanted to add on is something that Ellen said and something that I think Jan mentioned about being humans. Being humans and including the gender in everything that we're doing, because either that we want to realize or not, there are so many differences between genders and how they are treated and how they treat each other. And this is part of being humans. And this is something that we often forget, that we are not talking with robots, making the connection to AI. We're not talking with robots. We're not talking with people that have only a rational mind. We are talking with people that are caring for other people. And what Thomas was saying earlier about how many people have anxiety. And we also seen that there is a rise in violence against health workers, and how everything is connected in the end, and how if we do not take measures now, we will suffer later. And what I wanted to connect this to is the fact that this year we're celebrating the Ottawa Charter.
Yeah.
We have such a big celebration this year. And if we look at everything, how many things have changed and how many things were reached from what we have there.
Yeah, absolutely. And thank you for also bringing this important landmark. I would like to resonate on one comment regarding the housing prices in big cities, which is a problem crossing all countries, at least in Europe. And this is a paradox, a clear paradox. On the one hand, it's very difficult to attract and retain workers in more deprived and rural areas. At the same time, it is difficult in big cities. One very last comment. Would you like to make any point on how this should be addressed politically speaking? Is there any clear, one very simple and single targeted idea about this topic, how to differentiate? Is it beneficial from the system's perspective to differentiate salaries, labor conditions, and so on, to try to somehow attract people more to one side than to the others? Are there side effects? Who would like to take this question? No one? It's a tricky one. Thomas?
So, I think it's interesting question. It's interesting question because usually young people after graduation prefer to stay in big cities, in big agglomeration, because they have better access to postgraduate training, better access to international exchange, better access to other parts of their life. Yes, and that's why, for example, in Poland, and I know that also in other European countries, it's problem how to attract people to rural areas, how to attract young professionals to underserved area where the working conditions and living conditions are much worse. So From my perspective and from my knowledge, people prefer to work in big agglomeration. And also in Poland, hospital directors have no problem with staff deficit in big cities, but they have cities and rural areas. So it's my perspective.
Thank you, Lydia. Thomas, in 15 seconds, does the WHO has any kind of recommendation about this positive differentiation within countries, or there is no one-size-fits-all solution, at least based on the current evidence?
Yeah, I think on WHO we have you all know the WHO retention, rural retention guidelines. They were updated in 2020, and I think they are very practical in terms of analyzing which policy interventions are effective around education, regulation, financial incentives, and personal support. But just a quick reflection in 10 seconds, Tiago, I think you are opening a big can here, because I think now if you look at the European Union surveys, what we see is that the young generation, the main concern is about the high living cost in cities. So I think it's something that probably I would like to elevate it a little bit, because I think that really is a very complex problem, but I think it really requires multifactorial solutions, and there is not a single magic bullet to sort out this. Thank you.
Thank you so much. So I think it's now time to pass the word to Alan. Alan, would you like to wrap up?
Yeah, thank you very much. Now, I leave the wrap up in the sake of time, but I want to give the word to our, unfortunately not to the 7th one, but I would like to ask Monica, Bea, and Thomas, just in 30 seconds, what is your key recommendations? How should we move forward to improve retention?
I want to go forward, because this is the idea that I've started with. There is no, and this is something that Thomas just said, there is no one solution that fits everything, that solves everything. And what I think that ultimately is the solution, if we could have one solution, is collaboration.
Super. Yeah, 30 seconds.
Yeah, I think for us, a mentorship, taking care of each other, and don't go into key performance indicators. As also Monica said, it's a human thing. So let health be a very positive and warm environment for those in need.
Super. Thomas?
My message is, I think we cannot continue pushing health workers by keeping tough working conditions, because it's not sustainable. I think it's a short-term gain for a long-term loss. So I think we need to improve the working conditions, to improve the mental health, to improve the satisfaction, to improve the retention, to improve the quality of the services, and to improve, at the end of the day, the sustainability of the system.
Thank you very much. Instead of wrapping up, what is not possible now, I promise all of you that we will move on working on this topic, and hopefully you will hear about from us again very soon. Thank you very much to Tiago, Andre, and the organizing committee, to our collaborators, to all our speakers. I'm very grateful that you made time and you gave us very fantastic ideas. Tiago, the last word is yours, and please announce our last webinar.
Yes, and also allow me to join you in giving this big thank you for everyone for such an insightful session. And please do not forget about the next and final one, scheduled on 18 May from 3 to 4 p.m. Central European Time. The format will be the same, on the topic transforming health systems through health and care workers to build new capacities. As you can see in the chat, I already pasted again the registration link, as well as a link to our WHO Collaborating Center. It was again a pleasure. Thank you so much, everyone, for your time, dedication, efforts, and really hope to see you again in our last webinar. Thank you so much.
Bye-bye.
Yes, bye-bye.